You emailed us about. Well, everybody can hear. Welcome, everybody, to this inaugural lecture of Jonathan's. It's such a pleasure to be here. I'm going to say a few words and then pass you over to Jonathan. I'll give you a little bit of the background. Jonathan qualified as a doctor in 1990 at Bart's Medical School, having done a BSc at UCL in 1987. He got his MRCP in 1993 and was a specialist registrar in North Thames from 1994 to 2002. He got his MD in 2001 on HDL cholesterol and coronary heart disease in type 1 diabetes. And he was a BHF research fellow with Robert Elkeles, whom I'm delighted to see in the audience as his supervisor. He got his FRCP in 2006 and was awarded the OBE in 2019 for his services to diabetes. He's been a professor for some time. He was initially an adjunct professor at Imperial in 2013. Then he became a professor of practice in 2018, and he was appointed to the clinical chair in medicine at Imperial, based at Chelsea Westminster Hospital, and started that on the 1st of October last year. And this inaugural lecture is for that prestigious appointment. Jonathan will talk about his clinical activities, and there are some people in the audience here who go back a very long way with him. I'm just going to mention one or focus on one. His clinical service for people with diabetes who've got foot disease. And I'm only going to mention this service had the best clinical outcomes of any reported in the literature, any in the world. And his work in that field resulted in several key publications. He was appointed to the National Clinical Director for Diabetes and Obesity post in 2013, and only recently relinquished that, but continues to have a senior role at NHS England in multiple long-term conditions. Correct me if I say anything wrong, John. I'm just going to focus on one or two aspects of his research because he's going to deal with those in much more detail. His recent population-based research in diabetes is outstanding. And his diabetes prevention program is just about the best, certainly the biggest, anywhere in the world. And he'll talk to you in great detail, but we should all be very proud of what he's done with that. His work on multiple long-term conditions is also outstanding. This refers to the clustering of clinical conditions within individuals in the population, some of which were unknown or even not suspected, some of the components of the clusters. All his work will lead to changes in clinical practice and policy, all his current work for sure. And some of it's going to serve as a catalyst for new discovery science to discover the mechanisms underlying the observations that he and his group at NHS England have made. On a personal level, he's been such a good friend and colleague to many of us at Imperial and to many others here in the audience, I know, and I'm looking at one or two. Let's go around. Jonathan, it's a pleasure to invite you to deliver your inaugural lecture aligning clinical practice, policy, and academia.
Thanks very much, Des, for such kind words. Des, you've covered it. No, thank you, and thank you to all for joining me this evening for this celebration event. And I know there are people online as well who couldn't make it in person, so I'm delighted that you've joined me. Thank you so much. Now, let's have a look. Yes, I wanted a catchy title, and hopefully this is reasonably catchy, but I also wanted something that reflected, I suppose, the three quite, well, overlapping, but in some respects quite distinct facets of my sort of professional career. Clinical practice, central to everything. National leadership and policy, which was unusual, I suppose, and obviously wonderful that I've had that opportunity, and also clinical research and academia. So hope the title fits. This is where it started. So I was born in South Wales, in Cardiff, actually, and this is me with my parents at the family home in at some point in the 1970s. So my mother was, and mother's family were all from the Welsh Valleys. My father, on the other hand, came from much further afield, and the family from the Gujarat in India migrated to the Seychelles, which is where my father was born. He went to school for as long as you could in the Seychelles, which took you to the age of 16. So if you wanted to do A-levels, you had to go somewhere else. So he travelled to London, actually, to do A-levels. Arrived by boat in 1953, did his A-levels in London, applied to medical school and got in Cardiff, and hence the liaison between my mum and dad. My dad actually trained to be a chest physician, worked for most of his life, actually, looking after occupational lung disease, pneumoconiosis, for the miners in the South Wales valleys who'd been down the mines. And he really inspired me into medicine. So this is where medicine started. There's a few characters in the audience who are smiling, who were there with me. So we landed, didn't we, in 1984. Darren and Martin and I had to start 2 weeks early because we hadn't done A-level biology, do you remember? But no, very happy years, lifelong friends made there, and perhaps most importantly was I met my wife there, Nafisa. This is us on our wedding day. Nafisa's had her parallel career in general practice. I've had to be very careful what I say over dinner about general practice, and will be very careful this evening as well, for obvious reasons. And our three children, Sophia, Sarah, and Adam, are all here today. The younger two have come from Bristol, where they're at university, and a few family snaps, look. That one, I'm not sure the year on the top one there, but that's in 2019 when we went to, that's us at Buckingham Palace. And that actually is in West Wales, in Tenby, which was a common haunt for us. That's with Ian and Lisa, and we spent many a holiday in West Wales in Tenby. So all very happy times. Onward to the sort of professional aspects, and I think it's probably fair to say that my pathway through has been a little unconventional, perhaps. Certainly, I was appointed a full-time NHS consultant, and I suspect that's not the case for the majority standing here for their inaugural lectures, but I was appointed a full-time NHS consultant in 2002 and worked as such for 11 years at St Mary's Hospital. So having taken on some local and regional leadership roles there, in 2013 I was appointed as National Clinical Director for Diabetes and Obesity at NHS England. And so thus began a very distinct, different second chapter to my career in national leadership. I was there half-time and other half-time at St Mary's. And superimposed on all of that has been clinical research, actually. And many of you have joined me in some of those escapades and projects. But in those early years, and I'll talk a little bit more on this, I suppose inspiration for research always came from the one-to-one doctor-patient relationship for us clinicians. But actually in the latter years, or the next decade really in national leadership, it very much swung my interest and emphasis more towards population health and therefore epidemiology and implementation of interventions at scale across the whole of England, which it afforded me opportunities to do that, which was lovely. So my clinical research very much morphed over the years. And now, as of 15 months ago, I've landed at Chelsea and Westminster Hospital, which is a lovely working environment with lovely colleagues, some of whom have joined me this evening, which is great, and at Imperial College as clinical chair in medicine. So the third chapter begins, I suppose. This is where research started for me. I've got a picture there of Robert, who's in the third row. So I undertook standard clinical training. I trained at Barts. I did the Barts SHO rotation, which took me into the East End of London and Essex. And then Nafisa and I moved to Northwest London, which was a big move, and that's probably our biggest geographical move of our lives, wasn't it? To the east, from the East End of London to Northwest London. And so I joined the St Mary's Northwest London Junior Registrar rotation, as it was called in those days, which ultimately, after Northwood Park and Edgware General, led me to St Mary's. And my bosses then, who were both here, so our chair, Des, and Robert were my bosses, and both inspired me really into research. And up until then, it had very much been just focused on service delivery within the NHS. And so Robert provided me with some soft funding in the initial months, and then I successfully applied for a British Heart Foundation research fellowship and spent 3 years in a lipid laboratory, seems very distant now, performing ultracentrifugation, spinning blood samples from my patients to separate out what's called HDL cholesterol, or protective cholesterol. Now, Robert and I were very interested in what appeared to be a paradox that, okay, so diabetes is increasingly common. I think everyone knows that. Probably 7% of the adult population now across England, and it's doubled every 20 years or so, that prevalence. The vast majority have type 2 diabetes, which is determined by many lifestyle risk factors. So as we as a population have expanded our waistlines, so we've seen more and more people with type 2 diabetes, and that's about 92% of everyone with diabetes. What's that? 3.8 million people across the country. A rarer, not rarer, but a less common form is type 1 diabetes, and that's an autoimmune disease, often with much younger age of onset. And Robert and I were spending clinics on Mondays and Fridays every week, noticing high protective cholesterol, high HDL cholesterol in these individuals, and yet they were protected, they were not protected from coronary heart disease, which high HDL cholesterol is meant to provide for you. In fact, they were at much greater risk of heart attacks and strokes, and that's what we looked to disentangle, Robert, in those years. I have to say, I don't think we solved the issue, and I don't think anyone has subsequently either, but it was very interesting, and they were productive years with a number of sort of original papers and some review articles there, but I very much got the bug for clinical research, and in some respects never really stopped after that time. I moved into a clinical lecturer post at Imperial College, actually, based at St Mary's after that, but was lured into my full-time NHS post in 2002. Now, my bosses, of course, became my colleagues, Robert and Des, and also Steve Robinson, and they gave me a free hand to set up the services I felt were worth setting up, and it was good times. I was allowed to get on with things, and I set up a diabetes renal service and a diabetes hypertension service and a diabetes HIV service and a diabetes multidisciplinary foot service, which I've chosen to highlight here, and many will understand why I've chosen that, and Des has sort of led us into that, and thank you for that, Des. But so Tandy Malley was our lead podiatrist for many years, and Tandy, Robert and and I would do the diabetes clinic on the second floor of main outpatients. And Tandy, I'm looking for Tandy, yeah, Tandy would look after the people with diabetic foot ulcers 2 floors below on the ground floor. And so if Tandy had someone with an infected foot ulcer, she'd run up 2 flights of stairs, she'd grab me, pull me out of my clinic room, I'd march me downstairs 2 floors, I'd have a look, write the antibiotics, and I'd have to run back up. So it was less than ideal, and so we decided that the best way forward was to do everything in the same place at the same time. And that's what we did back in 2002. Tandy and I joined forces with Nick Cheshire, our vascular surgeon, with Don Hogg, our shoemaker or orthotist, and over the years that expanded. Denisha Samarasinga, our microbiologist, Carolyn Gabriel, we even had a neurologist, Carolyn is here, and our orthopedic surgeon, Pete Rosenfeld. So we expanded, and that's my leaving do, actually, and it was a much bigger team, and we started at 1 clinic a month, and we finished with 2 clinics a day, I think, when I left. And it was, so I suppose one of the principles was I always used my clinical services as my research base, really, and they were reasonably productive times. We published quite a lot over that time, but most importantly, we were able to expand because we could persuade the purse string holders that we were improving clinical outcomes for patients, but also reducing expensive inpatient stays. People were needing to come into hospital because of what we were doing in the outpatient setting. And the one I've highlighted there, Des has already mentioned. And in the late noughties, amputation of the leg is the most feared complication in people with diabetes. And we were able to show really very low major amputation rates as a result of the setup, everyone in the same place at the same time on a regular basis, pulling in the same direction for the patients. And so when we published that, those were some of the lowest rates in the world, which was nice. So hold that thought. I'm pressing the wrong button. And then I moved to NHS England in 2013, and Bruce Keogh actually recruited me back then in 2013. He was the National Medical Director, and then a year later Simon Stevens joined. In fact, a number of us were appointed all at the same time, and I've got Celia Ingham-Clark with me, and you and I were appointed the same day, Celia, I think, weren't we? So a number of us as national clinical directors were appointed. Simon Stevens and Bruce were phenomenally supportive and facilitative in much of what we wanted to do, and I'm really grateful to that. And as the years flew by, Steve Powis took over from Bruce and Amanda Pritchard in more recent years from Simon, but always very supportive. Now, Matt Fagg and I established the National NHS England Diabetes Programme in 2014-15, and then the NHS England Obesity programme in 2019, and as Matt was promoted to bigger and better things, so Tom Newbound took over, followed by Sean Crowe in more recent years, and I had a sort of partner in crime. Partha Carr was our national specialty advisor who very much focused on type 1 diabetes and access to technology and did great things in that space. That's a picture of my leaving do, actually, so that's at the end of the 10.5 years, but thank you to many individuals who supported me over that time and many people in both the diabetes and the obesity communities. But what worked so well was a triumvirate. And it wasn't just us lot in NHS England. We worked in partnership with colleagues in Public Health England, and Alison Tedstone led the nutrition team there, so we worked very, very closely together. Alison's here. And with diabetes, our third sector colleagues, Diabetes UK, and that was a phenomenally powerful triumvirate axis, really. We got, Bridget, I found a picture of you on the internet, you're here in the audience somewhere, and Bridget ran sort of policy and care at the organisation for, am I allowed to say 27 years? I think that's correct, isn't it? And we stood down within 2 weeks of each other, actually. And in the early years, the CEO of Diabetes UK was Barbara Young. Baroness Young sat in the House of Lords, taught me lots of very useful tips about political manoeuvring, and then Chris Askew took over from Barbara. But we all worked very closely together in phenomenally productive times. Now, I thought it might be interesting to just take you through some principles of national programs of work and, if you like, policy implementation. And I've listed 6 for you, which I think are really important. Number 1, granular data collection to support evaluation. And that formed the basis of everything that we did. Now, we're blessed in England in that general practice has been paperless for 25 years. Every single health data point is recorded electronically, and we can access all of that data. Now, in diabetes, due to the vision of Bob Young, and I'll come to Bob's achievements, Bob set up the National Diabetes Audit 21 years ago, and it became a fully comprehensive register of everyone with a coded diagnosis of diabetes across the whole country, and latterly, to support evaluation of the diabetes prevention program, everyone with a coded diagnosis of pre-diabetes as well. So we can wrap around. We've got a unique patient identifier. All of us have one in England, and that means we can link all of the national data sets and evaluate lots and lots of things very useful. And that was phenomenally powerful, and I'll give you examples. Second point, if you've got an opportunity with funding to do something new across the country, follow the output of good quality research evidence, follow the evidence, implement evidence-based policy. But often the political winds would blow us in directions where there wasn't very good evidence, actually, and we still had to move. Alison knowingly nodding, yes, we did that, we lived that. And you would have to move into a space with interventions that didn't have high-quality evidence, and in which case the principle that we adopted was pilot and evaluate. And I'll come back to that theme, because I think there's real opportunities now moving forward around that. Fourth one is accelerated access. Now, it's said that it takes from inception of research idea to routine implementation in routine practice and policy. It's a minimum of 17 years and often a lot longer, and that needed to be shortened. And so we undertook to, when good evidence did come out, to run with it as best and as quickly as we possibly could, and I'll give you an example of that. Narrowing health inequalities were constitutionally required to be mindful of that. And finally, if you want to implement something nationally, and it involves lots of extra work for the current healthcare professional workforce, it ain't going to happen. There is not the capacity. So I'll give you some sort of ways around which that we got around that. Now, this is I won't cause you to memorize this and test you later, but this is a fairly comprehensive list of all of the national programs that we implemented at scale across England over those years. The blue are lifestyle interventions. The purple, we got funding through very specific aspects of diabetes care on the back of the 2015 general election and the subsequent UK Treasury Comprehensive Spending Review. The top one was bolstering routine diabetes care. The next one, empowering individuals with access to structured education. The third one was better access to multidisciplinary foot care. So the model that we set up, Tandy and I back in the day, that we set up at St Mary's, there was building evidence that could reduce amputation rates, and so we wanted to improve access there, and also better access to inpatient care. 1 in 6 of every hospital bed across the country is occupied by someone with diabetes. The green areas relate to some of the things that Partha led on, including technology for access for people with type 1 diabetes, and a number of others, and I won't list all of them, but in particular, building on the success of what was the National Diabetes Audit, which has been running for 21, 22 years, we established the National Obesity Audit 2.5 years ago now. I'd ask you to hold the thought around multidisciplinary diabetic foot care. So we got funding. It amounted to 40 to 50 million additional funding for improving access to the sort of model of care, well, the exact sort of model of care that I described that we set up at the turn of the millennium at St Mary's Hospital. And as I stood down, we just about had reached universal coverage for the whole country with such a service. And this is the cardinal endpoint. So this is the rate of amputation across the whole of England in people with diabetes. And we started the decade at 9.1 per 10,000 people per year with diabetes, and we landed at 7.7, which is one of the lowest rates for a national, for a country, as it were, internationally now. And that's been recognized by the Commonwealth Fund and OECD countries, etc. We realized we'd got very good at saving legs, but not necessarily saving lives. And this is our own data. We developed an extra module of the National Diabetes Audit looking specifically at foot ulceration and presentation, and staggeringly high death rates, really, for people presenting with diabetic foot ulcers. 20% had died by the 2-year mark following presentation, 40% dead by 5 years. And this felt like we were doing well on avoiding amputations, but what about saving lives? And so I introduced a pathway. This is a number of years ago now, and we needed 5-year mortality data, so it took me 11 years altogether. But we started introducing 12 lead ECGs, cheap and cheerful, into the care pathway for everyone presenting with foot ulcers in 10 specific centres across the country, which allowed us, with the use of audit data, to have comparator centres where that wasn't the case. And so we compared about 3,000 people who went through a pathway with an ECG to 25,000 who didn't. And at the 5-year data, and we published that just only earlier this year, actually, there is a signal of mortality benefit in those that had an ECG, which is nice to know. And we've also got an NIHR funded, we've got Kamlesh here, we've got a multi-centre NIHR funded trial now called MI Foot, which is focusing on much more holistic care, addressing all those risk factors for cardiovascular disease and early death. And we'll see what that shows. So, change of tune. So many have asked, well, what makes you pick what you pick? You know, why did you deliver a diabetes prevention program? Why did you set that up? And so it's opportunism, if I'm honest. So you follow the political winds. In 2014, the NHS published a strategy document ahead of a general election, which was a first in my memory, and was then adopted post-election, but called the 5-year forward view, to quote, "The future health of millions of children, the sustainability of the NHS, and the economic prosperity of Britain all now depend on a radical upgrade in prevention and public health." Prevention, that was the buzz term. We already had in diabetes high-quality randomized controlled trials on 5 different continents, showing that if you took people with what we call pre-diabetes and you put them through this intervention, you reduce their risk of progressing to type 2 diabetes, or you certainly delay it. And so I put the case forward. And it got landed in, and it was put into the strategy document, which was implemented post-general election, and we got the funding. And so, hence, we had an opportunity. Now, so rule of thumb, if you've got an opportunity and funding to implement a new program, surround yourself with the best brains in the land, and that's what I did. And thank you to all of these. Kamlesh is here in the audience. And Emma is as well. And so I set up an expert reference group. We met from early 15 until I stood down sort of 8.5 years later. We digested the best evidence nationally, internationally. We drew up what we called a service specification, the description of a service that we felt the evidence pointed us in the direction of. We used the service specification to then run a national procurement exercise where we appointed providers who were capable of delivering on the content of that service specification anywhere in England. And the crucial point, going back to one of my principles, all of the providers, we then selected 4 providers, we put them on what we call a national framework, and each local area could select the provider that best met their local population needs. The intervention, it's not rocket science, actually. It's a 9-month intensive lifestyle intervention focusing on losing weight, exercising more frequently, and eating more healthily. We've heard that before, haven't we? But that's what it did. And so our providers didn't get paid unless they populated a minimum data set of every participant every month. With NHS number, we can link to all of our other data sets. So we automatically had the means to evaluate as well. So a 9-month intervention, essentially group-based face-to-face, was where the evidence sat. Now, we spent financial year 16-17, the first wave of rollout, we hit 51% coverage of the country. Next financial year, we hit 75%. And by summer of 18, we were the first country in the world to achieve universal coverage. And we'd already started analysing data, led for the large part by Emma Barron here in the audience. Oh, and you know, the first paper there that we published, Barron et al., looked at equity of access, and this is the narrowing health inequalities, The secret was ask the minimum possible of general practice or any other healthcare professionals, because they're too busy and there's no capacity. So hopefully the GPs in the audience will nod. But you know, the idea was the only ask was to identify the people who had pre-diabetes, and then you, is this right? Press the green button and they get referred in, and the providers do the rest, and we collect the data, populate data sets, do the analysis, etc. And we were able to show in that first paper that GPs were overrepresenting those from the most deprived communities who are at much more risk of type 2 diabetes, and those from South Asia and African Caribbean communities as well, who are also at much greater risk. So it was already a sort of equitable route through with overrepresentation. And we've published lots over the years. The next one, that was the first one to show our weight loss trajectories on program and our glucose reductions on program. So this will be familiar certainly to Alison and probably Celia. So we appointed the providers to the network, and I was taken aside, I think by Secretary of State for Health, to say, well, what's going on? Everyone does everything digitally. We do all our banking digitally, and you haven't appointed any digital providers to the framework. Why not? And we'd always said that we would follow the best evidence, and there was very poor evidence for digital modes of delivery when we first set up in 15. But because of those political wins, we established a pilot. It was more than a pilot, really. It was a study. It was adequately powered with 3,500 patients. We implemented 5 different digital products across the country, and we looked at its effectiveness at the 12-month mark, and the weight loss and the glucose reduction was equivalent of digital modes of delivery compared to our group-based face-to-face approach. We got this data literally a few weeks to maybe 2 months before onset of the pandemic, which meant that we then had the confidence to morph the whole program to digital and remote delivery when group-based face-to-face delivery ceased to be possible. We were also delivering, all of our providers were training up lay people as health coaches. We were not asking healthcare professionals to do anything in delivery. So the show went on in COVID times. I think we put through 250,000, Emma, during COVID times, probably, something like that. And we've got lots of results. It does what's written on the tin. This is one of our own graphs. I think you drew this one, Emma, just showing the dose-response relationship. So people can attend a maximum of 13 sessions. And this is the conversion rate from pre-diabetes to type 2 diabetes per 1,000-person years. And you can see that the more they attended on program, the lower their conversion rate, basically. Now, we were investing tens of millions of taxpayers' money in this, and we felt it prudent not just to be seen to be marking our own homework. And the NIHL were fantastic in supporting us with an independent evaluation. They commissioned the University of Manchester to do that, actually, and they've done amazing work, both qualitative and quantitative. And 2 of their papers, they've published many, many papers. I think for the whole program now, we're approaching 100 peer-reviewed publications in the international literature, but they were able to show very clearly that participants had lower rates of developing type 2 diabetes, and cleverly exploiting the phased rollout of the program in waves using what's called a difference analytical approach, they were able to also show reduced incidence of type 2 diabetes at English population level, which I hadn't necessarily expected, which was lovely. Now, this is just a slide to show you that my interest in diabetes prevention goes a little bit further than the national program. This is a very enjoyable piece of work. Sophie, you've been part of that as well, with John Chambers leading. This is NIHR funded the Imperial Global Health Research Unit on diabetes and cardiovascular disease in South Asians. And we've been collaborating with colleagues in India, Pakistan, Bangladesh, and Sri Lanka on various aspects of research into diabetes and cardiovascular prevention and treatment. And the bit that I'm most involved in with Nick Oliver, who's there in the second row, is we've developed a digital product, an app, that goes on mobile phones, that can go on mobile phones that people have in villages in India as well. And so we are running a randomized control trial at the moment to test its effectiveness in both rural settings and urban settings in Chennai and in Delhi to see if it's effective. That's me in Chennai this summer, actually, at one of the urban recruiting sites. And our partners in Chennai are just fantastic. The Dr. Mohan Group, they have a chain of around 50 different centres in the south of India and are just phenomenal at recruiting for trials and delivering excellent, fantastic standards of care as well. So I'm going to move on now and trying to catch Roy's eye. Where are you, Roy? Yes. So, the other thing where good evidence, well, this is the example of accelerated access, okay? So when good evidence emerges, run with it as quickly as you can. And this was timely. Roy, you published the direct trial in 2018. It proved your hypothesis over many years, I think, correct me if I get any of this wrong, but I think I'll get it right, that profound weight loss in the early years of type 2 diabetes can dissolve away a lot of the fat deposition in the pancreas, which allows the pancreas to start functioning normally again and can put people into remission of their type 2 diabetes. Now, this turned attitudes on its head when it came out. We'd all considered type 2 diabetes to be a sort of inexorably progressive disease with higher and higher sugars as the years and decades go by, and this really did impact. I've never seen a piece of research sort of get so much, received by so much enthusiasm within the community, patients especially, and we wanted to run with it, but I hope you don't mind me saying, Roy, delivery had been by healthcare professionals. We could not roll out the program nationally, asking healthcare professionals to disinvest time in one thing and invest in this. So in the same year, 2018, the Oxford group, Susan Jebb, Paul Aviard, published a very similar intervention, not in a diabetes population as it happened, where delivery was by commercial organizations and lay people trained up as health coaches, same model. And so we combined that. I made the case in the long-term plan, which was the next 2019 strategy document. It was accepted, put in, we got the investment, we started rollout in 2020, and we completed national coverage earlier this year. This is our weight loss on program. The mean weight loss as people come off at the 12-month mark is 10 kilograms. That's pretty sizable. And we published this summer in Lancet D&E our remission rates. Now, Roy's remission rates in his trial was 46% in remission at the 12-month mark. Ours is 30%. When you implement in the real world, you do not get the same effect size as you do in the ideal environment of a randomized control trial. And this, for me, is really important. We saw exactly the same, actually, in the diabetes prevention program. We saw excellent sort of reduction in progression rates, but not to the same extent as the randomized control trials. And Marta Koch, the editor-in-chief of Lancet D&E, was very kind in allowing me rant on about this in an opinion piece, correspondence earlier this year. Because I think it's important. Policymakers need to know what the effect size is in the real world. And if it's going to be less than the randomized control trial, you can't put your sums together very easily without knowing. And so very important that we publish such work and tell the world of our experience. Now, on this same theme, Shivani and I and Kamlesh are involved in a multi-centre EU Horizon-funded trial taking the same principle, really, and this is so we can take drugs tested in randomised controlled trials where everyone says, gosh, it reduces heart attack rate by 50%. Well, does it in the real world? And what we can do is look at when those same drugs tested in the trial setting are prescribed in the real world. We've got real world data. We can see what the effect size is, and so we can measure that attenuation, what's called the efficacy to effectiveness gap. And that trial's exciting underway now. So I haven't mentioned the third program, which is the digital weight management program, and I won't because of time. We used a very similar model for evolution and implementation, and this is a much lower cost, 3-month intervention on mobile phones for people. But while the evidence behind these programs is strong, internationally, there's little evidence beyond about 24 months for what happens if you put people through a weight loss program. And so the maintenance of weight loss is a bit of an unknown. And so so this is a collaboration with Amy Ahern in the University of Cambridge, again NIHR funded, where we will be taking people, this funding started actually only in October, so this is new for us, but we're taking people coming off the back of the national programs and putting them through and testing an intervention to see if we can more effectively maintain the weight lost on program. Let me turn attention a little bit now to the routine diabetes care that we try to deliver in our own clinics, regionally, nationally, whatever, and how that relates to clinical outcomes. Now, I've mentioned Bob Young already. So Bob had the vision to establish the National Diabetes Audit in 2003. Bob unfortunately passed away this summer, but his legacy will live on, and the benefit, the tangible benefit to the diabetes community over many years now and into the future, is huge. Every single person with diabetes is recorded in there. Every single person now with pre-diabetes to support evaluation of the diabetes program. We got modules for foot disease, for pregnancy, for technology. It's an amazing resource. But Bob set it up initially to assess adherence to national guidelines, NICE guidelines actually. And we are meant to, according to guidelines, deliver those care processes, the 9 of them on the left there, to each person with diabetes every year. And we can use that as a sort of metric for how well we're delivering routine care. And we've also got treatment targets for what we call the 3 treatment targets around glucose, around blood pressure, and around cholesterol, the 3 treatment targets. And all of those in 2004 were incentivized via, incentivize, is that the right word? Got to be careful what I say, obviously, looking at my wife. So financially supportive of general practice to deliver that care annually with extra monies. And I think 100 million per annum has been invested on diabetes care over the last 20 years to support delivery of these care processes. Now, many GPs, being careful what I say, think this is a rather annoying box-ticking exercise. But we would argue otherwise, and this is work we've done over the years using both National Diabetes Audit source of data and also CPRD, forgive the abbreviations. It's a general practice-based research data set. And, we've been able to show that care process delivery today is associated with lower death rates, lower mortality 4 to 7 years down the line, lower hospital admission rates, lower amputation rates, and lower eye complications in people with diabetes. So we would argue that this is more than a box-ticking exercise. It's done huge amounts of good for the population with diabetes over 20 years now, and we hope we don't lose pay for performance, or QOF as it's called, Quality and Outcomes Framework. So if you give good care, you get better outcomes. What happens if you take routine care away? And of course, that was forced upon us to some extent, wasn't it, during the pandemic? And so we've often used completion or delivery of all care processes. What proportion of the diabetes population each year have had all of those care processes delivered? And if you look at the red line there for type 2 diabetes, you can see that we were making progress year on year, and then COVID struck, and it fell. In the summer of 21, as National Clinical Director, I was approached, I think, by Public Health England then in the summer still, or was it the office, it had become the Office for Health Improvement and Disparities. But I was approached and said, look, we're a bit concerned here. The death rate at English population level is going up. And it's going up much more so in people with diabetes, and we don't really know why, but this is not COVID mortality, this is non-COVID mortality. And so using our access to data, we measured per individual the degree of fall-off in routine care during that first year of the pandemic, and showed a very clear association between this excess death rate a year and a half on, and the fall-off in routine care delivery. So it really is very important. And we use that as leverage to get more resource to support routine care recovery following the pandemic. And over the next 2 years, hopefully those graphs persuade you that we probably achieved that. Turning thoughts a little now to longitudinal changes in population health and life expectancy. This used CPRD, actually, and so this end is turn of the millennium, and this is just before the COVID pandemic. And this is the causes of death in people with diabetes, okay? And the blue area was the commonest cause of death, almost 50%, certainly in the 1990s and at the turn of the millennium, and that's heart attacks and strokes were the commonest cause of death. Look what we've achieved. Now, some of this is societal with reduced smoking rates, but we can suggest that this was the focus that we've had on the 3 treatment targets, which tackle cardiovascular risk factors, basically. And we've seen this amazing diminution in cardiovascular causes of death. We published a similar paper on rates of hospitalization, which showed almost an identical picture. But for the hospitalization, you really see large proportions of causes of illness from infections, urinary tract, chest infections, and cancers, actually, which are not the cardinal complications of diabetes. And this brings in the concept of multiple long-term conditions. Now, as a diabetologist practicing, almost all of my patients that I see now don't just have diabetes. They've got many other long-term conditions, often multiple. It's the same in general practice, coming through the doors in general practice. It's the same in people being admitted through the doors of A&E. This is the clinical reality for us now. We've achieved, and this is a phenomenal achievement, we've got increased life expectancy of people with diabetes in this diagram, and probably the whole population, but that's allowing people to live to older ages and develop multiple long-term conditions, and that's presenting its own challenges. When I stood down 15 months ago, I was asked, what do you think the two priority areas are? And I said, well, the first is this entity, multiple long-term conditions, and how crafty was I? So I'd established a work stream in multiple long-term conditions 2 years before standing down, and when I stood down, I carried on the leadership of that little bit. So I still have my affiliation with NHS England around multiple long-term conditions now, which Des has alluded to. But this is the challenge for the health service into the future. And the other issue is younger onset type 2 diabetes. As we have expanded our waistlines, so we're seeing younger and younger and younger age of onset of type 2 diabetes. And these people will develop complications at young age and will be the multiple long-term condition people at much younger age of the future. Just in terms of what we've done, a few slides on multiple long-term conditions. Now, I'm turning the clock back a few years. To COVID, early 2020, before we'd seen the first case, we had the early reports out of Wuhan that people were dying of COVID, but it would appear very early on that people with diabetes seemed to be overrepresented in those dying, which was a real worry for us. And older people were also dying, and diabetes is more common in older people. So, you know, how did we disentangle? We realized that we could disentangle using linkage of the national data sets. So we linked the National Diabetes Audit with the Master Patient Index, which you may not have heard of, but that includes all of us. That's everyone in England registered with a GP, to something called the Bridges to Health segmentation data set, which corrals many different national data sets from national audits, community environments, hospitals, and it essentially gives us registers of many other long-term conditions. And we linked that to ONS mortality in the COVID patient notification system. And we were able to, I think we were the first to show internationally, so the first 2 papers there were published in the summer in Lancet D&E, but we put them up as preprints on the NHS England website, I think in week 11 of in May of the lockdown. And so for the first time, we were able to express quite accurately, compared to the non-diabetic population, N equals 60 million. So we were able to show the increased absolute and relative risk of dying from COVID if you had diabetes by type of diabetes. And that was the first time it had been described for COVID and for people with diabetes. And it was productive times. We disentangled some of the other unknowns as well, but fundamentally we realized we were sitting on this gold mine that we could mine for much more information around this entity that we're all seeing clinically called multiple long-term conditions. It's defined as 2 or more of a physical long-term condition and or a mental health long-term condition or a chronic infection. And so, you know, using the same data, we've got 60 million people, we've got registers essentially of 35 common long-term conditions, and it's longitudinally accrued data for the last 8 years or so. We can, a little bit of analytics here, segments the English population. 34 million have no long-term conditions, 17 million have a single, 9 million have 2 or more, the entity, MLTC, and 1.4 million have MLTC plus frailty. Now, we've evolved a health system over decades that has become very good at addressing number 2 and number 4. We've got lots of resource pumped into that. We've got lots of clinics that deal with that, but we haven't got much in the number 3 space, and so I suppose that is one of the ambitions drive that we would like to achieve, although it's not easy knowing what we do differently. More characters here who've supported me. Our chair, of course, is part of this group, and Des, you linked us in with the NIHR Clinical Research Network when we started this 3 years ago now. But we've done a lot more data crunching. Emma Barron is core to this. aren't I clever? She's come with me from NHS England to Chelsea and Westminster, and despite being a highly accomplished analyst at NHS England, hadn't done her PhD back in the day, and is now joining me to do that too. So wonderful. And these are a couple of papers we put out more recently. So the first one is a prevalence piece looking at the prevalence of this entity, multiple long-term conditions, but breaking it down by age and sex and ethnicity and deprivation. As Des mentioned, we can see associations between conditions that we as medics didn't really know about before. Now, that might open the door to new sort of biological mechanisms. And we also published in the summer in Nature Medicine, these were somewhat newer epidemiological descriptors. So any combination of diseases through Markov modeling, we can look at, so in this paper, we looked at diabetes plus another condition, might be schizophrenia, might be Parkinson's disease, maybe coronary heart disease. And we can look at the median age of onset. We can look at the number of years lived with that combination, which was important for NHS England to get a handle on the resource implications, and the number of years lost to the premature mortality implications. And the other priority I talked about was young onset type 2 diabetes. And we did some data analytics here. Shivani, you've led a lot of this work, and Shivani is the rising star, really, in this field, probably internationally now, actually. What we managed to disentangle with the English data was characteristics, much more likely to have raised body mass index, much more likely to be living with obesity, much more likely to be from non-white ethnic groups in England, and much more likely to be from deprived areas. And actually, just before I stood down, we managed to get quite a sizable additional investment in improving the care for these individuals. They don't access NHS care well. In fact, people of working age generally don't. So we've got extra resource, and Shivani is part of that national leadership team now, I think, doing the data analytics on that. So I'm going to wind up with some thoughts. You know, what are we going to do about this multiple long-term condition thing? Well, that's a good question, and what do we need to do differently? And there's lots of thoughts around how we have... I mean, I think fundamentally we need a movement back to generalism from ultra-specialism. A lot of the prestige in medicine for decades has sat with ultra-specialisms, but actually what we need is more generalism, and everyone thinks that's general practice, which of course it is, but the likes of me had to spend... and Des and Robert and others, I spent decades doing general internal medicine, taking all cases through the doors of A&E as well. And so we've got to harness that generalism. This is interesting. What about prevention in the space of multiple long-term conditions? Well, we've got 1.7 million people now referred into the diabetes prevention program. The top panel, so this was what we call post hoc retrospective, sort of searching for potential signals. And we looked at people who had gone all the way through the diabetes prevention program, and we matched them for everything we could possibly measure with people who looked the same but hadn't been through the program. And the top panel shows you the reduced rate of type 2 diabetes. Well, we know that already. But the bottom panel looked at associated long-term conditions like depression associated with the sort of potential benefit of lifestyle interventions, cardiovascular, other conditions. And there's just the suggestion in that lower panel of a potential benefit in reducing incidence of other long-term conditions. Now, my last slide-ish, almost last, is somewhat speculative in that we haven't got the green light to do this, but this is what we'd like to do, and the stars might line up. But in terms of the pilot and evaluate principle, it feels like we could be much more experimental in dealing with that piloting and do it as a proper sort of study type approach. And so what we would like to be able to do is to take a different high-risk population, hypertension people living with hypertension, put them through the same program. All of our 4 providers are able to morph the program to do that for us and actually measure the end point of an additional long-term condition, not type 2 diabetes, but to see what the effect is more broadly on other long-term conditions. Now, we would like to approach this, if possible, as a step wedge cluster randomized study design, and the stars might line up for us, but a few of them still need to line up. But I think this could take policy implementation across the country into a real, a newer era with much more alignment of research and policy implementation. And I'd like to think that in my new role, I could perhaps facilitate that, and we'll see if the stars line up. And we've got a number of others, Kamlesh, you and I have talked about a number of other potential cluster randomized trials that we could run under the banner of pilot and evaluate. So loop back, granular data collection. I hope I've shown how important that can be and how useful it has been. Follow the evidence. The Diabetes Prevention Programme did that. Pilot and evaluate. Well, lots of examples. The digital bit of the programme, of the Diabetes Prevention Programme, did that, but we've done lots of other pilot and evaluate and lots to do more in the future. Accelerated access, you know, Roy, you published in 2018. We got it into policy in 19. We started rollout in 20. That's pretty, hopefully that opens a new era of acceleration, if that's the word. Narrowing health inequalities. Well, it's hard, but we've tried hard to do that. And I won't go into details, but the latter lifestyle intervention has done that the best, actually, by overlaying additional support for those least likely, from more disadvantaged areas who are least likely to pass all the way through a program. And so that's sort of core to much of what we do. And of course, the workforce capacity issue, I think I've given you the impression that where it's worked well is where we haven't needed to ask much of the healthcare professional workforce because it's full to busting. So to conclude, I hope I've persuaded you of the value and the utility of real-world data to track routine care outcomes. I've used diabetes as an example, but we can do that for many other conditions across in the country, given our resource of data. We've had a successful focus on cardiovascular disease risk reduction. I've shown you the data for diabetes. That's happened at general population level. Us as well. We saw increased longevity over those 20-year period, particularly during the noughties, actually. Probably most impactful was reducing smoking and increased longevity, but we've certainly seen that in diabetes, resulting older attendees with multiple long-term conditions, bullet point number 3, expanding waistlines, driving young onset of type 2 diabetes, which is the multiple long-term condition substrate, if you like, of the future. Now, I've been trying to spin a fourth narrative whenever I speak, which is, a narrative around a fourth treatment target. The 3, glucose and blood pressure and lipids, but we need weight reduction to be a real cardinal part of routine management. Now, I've given you some information on what we've done around lifestyle, but of course what we have now is this very exciting new era of a pipeline of drugs that actually work to lose weight, which we read in the newspaper every other day, or probably every day. And finally, I think there are real opportunities methodologically about doing the piloting and evaluating piece of policy implementation more experimentally, really, and if we can cause that to happen through different affiliations at Imperial, for example, and Chelsea and Westminster and national role all combined, let's see if we can make that happen. So thank you to all for all of the support that many of you have given me over many years, and thank you for listening.
Jonathan, I think I speak for everyone when I say that that was an extremely engaging and thoughtful summary of your entire career. It was an absolute pleasure to listen to that and to be in the room. We've got probably a few minutes for 1 or 2 questions. It's open online as well, so if you do have a question, pop your hand up. We can take, lady in the red there. Just say who you are and what your role is.
Hi there. My name's Mabel. I'm currently doing my PhD here in first year. Thank you so much. That was fantastic. I was interested in the area of you talking about the data about lower socioeconomic groups and that being transferred into the intervention stage. And I was wondering what kind of areas or research or types of people have been investigating culturally specific intervention in your work. Thank you.
What a good question. This is important for us in diabetes, and you're probably aware, and that's probably why you asked the question, but type 2 diabetes is much, much more common in people of non-white ethnicity, if that's what you mean by cultural tailoring, and we were aware of that. There is a whole raft of qualitative, I've shown you quantitative analyses today, but we've got rafts of qualitative work, and we have specifically looked, particularly for the Diabetes Prevention Programme is where I've sort of majored today, and we've done lots of work in communities up and down the country. I'm trying to think where we did that. Birmingham, some centres in London, where we targeted specific cultural groups, whether that meant going to religious places, to mosques to try and sell the message. Because in some communities, certainly community leaders can be so persuasive in bringing on board that sort of local population. And so we've done quite a lot of work on that. I didn't major on it, but it's important in everything that we do. We have to, constitutionally in NHS England, be mindful of dimensions of inequality. In diabetes, that's particularly so for socioeconomic status and for ethnicity. And so, yes, I've not answered you very specifically, but we've done quite a lot of work there in terms of trying to recruit people into programme. So what we see is overrepresentation in the referral cohorts, but not necessarily maintenance on programme. People drop off. Interestingly, when we moved digitally, we shifted the entire age distribution of participants by a decade to the left by digital modes of delivery. Now, I don't know if people know this. Mean age of the white population in England, anyone know? 42 years. Mean age of the South Asian population in England, 32, whole decade younger. And for the black population in England, 33. So by shifting the age distribution with digital modes of delivery, we captured many more people than we otherwise would have from South Asian ethnic groups and from black ethnic groups as well. But that was rather fortuitous. We have done focus work, as you suggest, as well.
I'm going to sneak one in myself, if that's all right, Jonathan, because I think we're running out of time. But I love these different phases of your career. And I just wondered, what was your motivation to change? Was it planned, or how did you sort of reinvent yourself into these new roles?
Oh, gosh. Well, it wasn't planned at the outset, but dare I say, by year 10, when I was sitting in my Monday morning endocrine clinic staring out the windows thinking, I was sitting here a decade ago and I am here today as well, maybe it's time for a new chapter, I suppose, was part of the motivation. I think if anyone wants a tip from me, every 10 years is a good time to think about whether you want to do something different.
Great. I think I've been told that we have to finish on time, so it might be... Is there another question? Roy?
Well, just to say, Roy Taylor, Newcastle. I was a Spartan back here, Jonathan. Congratulations.
Thank you.
One of my concerns about both the path to remission of type 2 and the pre-diabetes is that the highly successful programs built on physiology, wonderful. But there's a human aspect and our relationship with the environment. And it's a food environment that hasn't changed. So we know that, for instance, in direct, the weight loss fell from 10 kilograms down to being 6 kilograms down at 5 years, not bad. But it's a food environment. Are you optimistic about being able to influence that from NHS England, the relationship with public health, etc.?
Well, you're sitting to your right is the person that dedicated much of her life to such things, Alison. And so certainly back in 2014, when we published the 5-year forward view, the idea was that we would have population-level interventions, and if you remember, the sugar tax came on the back of that, and we would have individual-level interventions, which we're good at in the NHS. We take individuals and we do stuff to individuals, whereas local and national government and public health do stuff at population level. So the intention was, there was a wide portfolio of potential actions back in 2015, Alison? 2015. Yeah, and then with changes in government, motivations for executing change. But the winds are blowing in the right direction, aren't they? As I read in the Times this morning. So maybe we will see those complement. Yes, quite. Thank you.
I think we're going to have to wrap up, but I'm sure there'll be an opportunity to ask more questions over the drinks. I'm going to hand over to Kamlesh for closing remarks. Thanks again, Jonathan.
Thank you, Shivani. Thank you, guys.
So my name's Kamlesh Kunti. I'm a close friend and colleague of Jonathan over many years. I've been asked to give a vote of thanks and a few personal reflections. A vote of thanks, really, to a number of people. First of all, the family for putting up with him. And then all the collaborators, friends, colleagues who are here, Des for setting us off, and for Shivani for taking the questions. In terms of personal reflections, the organizers gave me a remit that everything has to be positive, unfortunately. So I met Jonathan probably about 15 years ago through diabetes collaborations, but I got to know him a lot better over the last 10 or 12 years since he got the important role as the director of National Diabetes Audit, National Diabetes Clinical Director's role. And we've worked over these years, as you've seen, on the executive group for the Diabetes and Obesity Implementation Group and National Diabetes Audit, and more recently the Multiple Long-Term Conditions Executive Group. And it's been a real great pleasure working with him. We have regular chats together, maybe 2 or 3 times a week, but it got quite suspicious during COVID. I think both of our respective partners were very suspicious because we were talking about 6, 7 times a week, particularly at weekends. I mean, these conversations would go on for an hour or 2 during COVID. And usually they were when he was pushing his trolley in the supermarket and I was pushing my trolley in the supermarket. And most of this was quite intensive conversations regarding the data that was being generated, particularly the COVID mortality rates, and trying to see how we can communicate that risk, what next we need to do, what do we need to do about this. But they were really deep conversations, and as I said, really enjoyed those long conversations as well. And we discussed all of these results in detail, and then policy actions came from that. And I think that's been really important, and you can see that story in Jonathan's lecture tonight. I think the next chapter in terms of the multiple long-term conditions is an important one. Multiple long-term conditions is going to be an epidemic. We talk about diabetes being an epidemic or a tsunami. The prevalence of diabetes, as you've heard, is 7%. Prevalence of multiple long-term conditions from Jonathan's work is about 14%. And it's going to continue growing. People are living longer, but in poorer health. And so the policy questions that are now important are exactly the kind of things he's reflected on. How can we make people live longer, but in better quality of life? And as Jonathan mentioned, we have the best data in the world. We have the best minds, statisticians in the world. And Emma has been part of every meeting we've had over these years. And I think these continuous discussions are really important, and we're hoping that these policy questions will be answered and will improve the lives of people with diabetes and multiple long-term conditions. That lecture today was a real tour de force in seeing how a clinician thinks about the important questions, thinks about how we can answer those questions, test them out, and put them into practice at scale to improve the lives of these people, as I said, in a very, very short period of time. So we're all very privileged, Jonathan, to have known you, to have worked with you, being a collaborator, being a colleague, and we look forward in your next chapter over the next 10 years. As you've seen, Jonathan is a world-class researcher, but everyone has a few things for development. So I'll just leave you with a couple of areas of development, Jonathan. One is etiquette. He's always immaculately dressed, as you've seen. But I emailed him 2 days ago and said, Jonathan, this is really special. You need to get your boss suit or an Armani suit out. So I walked in and said, Jonathan, what happened here? And he said, I do have an Armani suit, but it's got flares. And I'm not sure, you showed the photo of your parents with the flares. I'm not sure if that's the Armani suit. So there's a bit more work to do there. The other developmental area certainly is Bollywood dancing. So Jonathan comes to a conference I organize every year. 12 years he's been there as our keynote speaker. And we have an event, gala event, and there's Bollywood dancing. and 12 years we've been working on this. And unfortunately, that's still work in progress. On that note, I'll bring this wonderful inaugural to a close, and we invite everyone here to join Jonathan and the family for drinks outside. Thank you very much.
Thank you. Thank you. Kamlesh, let's get some photos.